Good morning. My name is Kayla Brewley. I am a third-year professional doctor of pharmacy candidate. In my journal club today, I will be presenting on pre-hospital use of magnesium sulfate as neuroprotection in acute stroke. The authors are Jeffrey L. Saver, Sydney Starkman, and Mark Eichsten. The National Institute of Neurological Disorders and Stroke, Field Administration of Stroke Therapy Magnesium fund this clinical trial. So, the background. Stroke is the second leading cause of death and a leading cause of adult disability worldwide. Neuroprotection is a treatment strategy that is complementary to reperfusion. The neuroprotective agents interrupt the cellular, biochemical, and metabolic process that mediates cerebral tissue injury during or after ischemia. This agent is safe and potentially beneficial in patients with hemorrhagic stroke or ischemic stroke. It may be given before brain imaging is performed to stabilize threatened tissues until therapeutic or spontaneous reperfusion. Magnesium sulfate is neuroprotective for stroke patients, and it shows that it has the potential efficacy to be a safety profile for drug delivery. Magnesium sulfate is cerebroprotective in different models and exerts vasodilatory, direct neuroprotective, and glioprotective effects. And our researchers chose this medication, the magnesium sulfate, because it's inexpensive, widely available, simple to administer, and it has a favorable effect of being a standard treatment for eclampsia and preeclampsia. The objective of this trial. The initiation of the neuroprotective agent magnesium sulfate would improve the long-term functional outcome of patients with acute stroke. Broader system goals was to show that enrollment and treatment of patients with acute stroke in the field as a practical and feasible strategy for phase 3 trials. The trial design, phase 3, multi-center, randomized, double-blind, placebo-controlled, pivotal clinical trial. The location, 315 paramedic staffed ambulances and 60 hospital sites in Los Angeles and Orange counties, California. The study protocol was approved by the members' institutional review board at each pre-hospital and hospital study site. Some inclusions for this trial: suspected stroke identified by the Los Angeles pre-hospital stroke screen, so you had to be over the age of 40. You needed to have a history of seizures or epilepsy absent. The patient could not be in a wheelchair bound. Their blood glucose needed to be between 60 and 400, aging 40 to 95, and they needed to have a well time within 2 hours of treatment. Some of the exclusions: if you had a coma, neurologic deficit, psychiatric, your blood pressure, your systolic blood pressure was over 220 or less than 90. Maybe if you had a severe renal dysfunction, you was excluded. If you had a second or third degree heart block with no pacemaker in place. If you had major head trauma. Some of the subjects, this whole study was based on female adults between the ages of 40 to 90 years of age. The primary outcome was the use of the ranking scale 3 months after a stroke that will confirm the degree of disability. The scale ranged from 0 to 6. The higher the scores, the greater the disability. The secondary endpoint was, it specified on the date of 90, but it included the results of recovery, minimal or no disability, neurologic deficit, good recovery, functional independence, and death. The duration time was between January 2005 and December 12, 2012, which gave you a follow-up around 8 years to max. The population, total of 1,700 patients. It was an under randomization clinical study. So 857 patients were assigned to the magnesium sulfate group and 840 to the placebo group. So they start off with 1,700, patients enrolled. 42.6% women. The mean pre-treatment score was the Los Angeles Motor Scale of Stroke, and the severity was 3.7. The final diagnosis of this event, the cerebral ischemia in 73.3%, intracranial hemorrhage in 22.8%, stroke mimicking condition 3.9%, and the last time patients was last known to be free of stroke, the symptoms and start of the drug infusion was 45 minutes, which gave it a 74.3% of patients receiving a study drug infusion within the first hour after system onset. Based on that, there was no significant shift in the distribution of 90-day disability outcomes on a global modified scale. The treatment will be beneficial in patients with cerebral ischemia. It will have a neutral effect in patients with intracranial hemorrhage or stroke mimicking condition. Among patients with cerebral ischemia, the shift outcome distribution was projected to be approximately 70% of the effect observed in a meta-analysis of phase 2 trials. But a primary efficacy evaluation tested the null hypothesis that the distribution of modified ranking scores was a 90-day, and it would be identical in the magnesium and also the placebo groups. Based on the results, the final diagnosis was the qualifying event were cerebral ischemia in 73.3%, intracranial 22.8%, and stroke mimicking 3.9%. With regard to the system goal of delivering, the median time from the last known time before onset of stroke symptoms to the start of study drug infusion was 45 minutes. So they're saying that that their goal, once they gave the magnesium sulfate, it was best to give them between the time, probably from 1 minute to an hour, and they seen an infusion starting, the symptoms starting to decrease around 45 minutes. And that's when your next onset of symptoms will come, which means it lasted about a good timing in the system. Some result, 74.3% of the patients received the study drug in the first 60 minutes after the symptoms had came, and then 24.7% in the following. With our primary endpoint of results, there was no significant shift in the 90-day disability outcomes on a ranking scale between the patients who were placed in the magnesium sulfate group and patients who were placed in the placebo group. Based on our scores, the results did not differ between the magnesium sulfate group and placebo group. It was between 2.7 in each group with a p-value of 1.00. The secondary endpoint, there was no benefit of magnesium sulfate therapy due to the 5 secondary 90-day efficacy and endpoints of excellent recovery, minimal or no disability, neurologic deficit, good recovery, and functional independence. So with this part, it's talking about how the heterogeneity of treatment, it didn't show an effect to the groups. The type of stroke, basically the cerebral ischemia or intracranial hemorrhage concomitant therapy with TPAs, the time from onset of stroke, symptoms to treat, age, sex, race, and pretreatment severity of stroke. From giving the patient that drug, it didn't show any effect on their cerebral ischemia, on their different type of strokes or feedback. But in the homogeneous effect, a distribution was shown on the ranking scores, which is the scale, and across the 7 levels. So it was divided between 0 to 1 versus the 2 to 6, and 0 to 2 versus 3 to 6. And on a ranking scale, it goes from 0 to 6, 6 being the highest, leads to differentiation. and the greater of the disability. The 90-day rate of death. Basically, this is the adverse events, was 15.5%, where the rate of symptomatic hemorrhagic transformation of initial cerebral ischemia was 2.7%, and the rate of asymptomatic hemorrhagic transformation was 6.3%. The serious adverse events did not differ significantly between the magnesium group or the placebo group. Overall, your score was 51.2% versus 50.1%, which is not much of a difference. Systolic blood pressure was lower by 3 in magnesium group than in the placebo group at the end of the 15-minute infusion loading dose from the 20th hour to the 32nd hour. But it wasn't far. The FAST-MAG Phase 3, it did not confirm the primary hypothesis that prehospital initiation of magnesium sulfate in patients with a suspected stroke during the hyperacute phase would reduce the level of disability at 90 days. So they see no difference in mortality between magnesium group or the placebo group. The strength of this article, it was a Phase 3, multi-centered, randomized, double-blind, placebo-controlled, pivotal clinical trial where it was incorporated to reduce bias studies. But the FAST-MAG trial enabled to achieve innovative trial design targets with testing pre-hospital treatment of stroke, number of patients within the first 60 minutes or after the stroke onset, and to see if the neuroprotective agent delivered in advance. But the weakness of it, there were several limitations in the study where the trial, it completed over 8-year period time, which is a very long time. And the delivery of conventional therapy, it didn't evolve over time either. So a small proportion of patients were lost in follow-up, or even if they was going through the final follow-up visit, and also provide assurance that the trial findings are reliable. It was very difficult to find that. This clinical study was performed to initiate the neuroprotective agent, magnesium sulfate, by paramedics in the field to improve the long-term functional outcome of patients with acute stroke. Patients were randomly assigned to receive either the intravenous magnesium sulfate or placebo within the beginning of 2 hours after the onset. The dose they gave them at the arrival, they gave them a 24-hour maintenance infusion. And then the primary outcome was at the degree of 90 days. It measured by the scores on a ranking scale, 0 to 6. But in conclusion, the FAST-MAG trial did not show a treatment benefit of magnesium sulfate administered in the pre-hospital setting among patients whom hyperacute stroke was suspected. But the trial was able to succeed in achieving delivery of the study agent to patients with a suspected stroke faster than in previous pivotal trial. Pre-hospital initiation of magnesium sulfate therapy was safe and allowed, and started therapy within 2 hours, within the onset of stroke symptoms, but it had no improvement of disability outcomes on the 90 days. The study achieved its systems by aiming the delivery of the study agent to patient with stroke faster than in the previous Phase 3. It became a golden hour, which is the first 60 minutes after the onset of stroke. Thank you. Once again, my name is Kayla Brewley. I am a third-year professional doctor of pharmacy candidate, and I had a journal club based on pre-hospital use of magnesium sulfate as neuroprotection in acute stroke. You have a great day.